This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, this is an interesting case of a pseudoexfoliation with a slightly denser nucleus, and I'm going to demonstrate the IOL trap technique in this eye. He is an elderly male patient who has this moderately dilating pupil because of pseudoexfoliation and a dense cataract. So let's begin. I'm injecting 1.5 ml in the subtenon space as a form of an anesthesia for this patient. I'm expecting the surgery to be slightly longer. There's a reason I'm augmenting the anesthesia apart from the topical drops. The two side ports are created. The anticapsule is stained. Dispersive OVD is placed into the bag and the main 2.8mm incision is created. The health of the zonules can be seen only when we handle the anticapsule. And the moment my forceps is trying to pierce the anticapsule to raise a flap, you can see these radiating folds emanating from the puncture site, suggesting a significant amount of anterior zonular weakness. Now is the time to perform the rhexis. The capsule is raised and the flap is being turned around. At this stage, I need to be mindful about the size of rhexis which I want to have. As there is evidence of zonular weakness, I would like to have an optic capture and use the IOL trap technique. But at the same time, the cataract is slightly dense. So I don't want a very small rhexis as well, which is going to make my nucleus emulsification slightly difficult. So I need to have a compromise. I think I'm going to aim at 5 or 5.5mm rhexis. That seems to be the ideal one. And that's what I got now. In eyes with weak zonules, I keep telling that, hydrodissection is probably the most important step, because we cannot proceed for the next step of the surgery until we ensure that the nucleus, epinucleus, and the cortex are all devoid of any attachment to the capsular bag. If the nucleus is still attached, further rotation and maneuvering the nucleus is going to worsen the zonular weakness. So there's a reason it's important to spend a couple of minutes extra to ensure that the hydrodissection is done and the corticocapsular adhesions are well and truly broken. Now in this case, before I proceed with the nucleus management, I'm going to insert the CTR now itself. It's going to act like an artificial zonule and provide 360 degrees zonular support. A little bit of OVD is injected underneath the anticapsule to create some space. Then the CTR is gently threaded into the capsular bag. And now we have the entire CTR in the bag. Time to phaco. The superficial epinucleus in the cortex is removed. And in this case, I'm consciously choosing the 4-quadrant technique to deal with this dense cataract. I'm going to use just the torsional energy on the machine to cut through the nucleus. The nucleus is stabilized with my second instrument and the sculpting process has begun. Once I reach about 30 to 40% depth, the nucleus is rotated 90 degrees and then the second groove is created. So it's important to note that when the sculpting process is being done, the nucleus is neither pushed or shooed around. It just gently cuts across the nucleus, progressively deepening the groove. We need to use adequate power so that we don't mechanically push the nucleus. The phaco and the ultrasound energy itself should cut across the nucleus. The nucleus is then rotated 90 degrees. The final groove is created. Supporting the nucleus with the second instrument does play an important role in ensuring good control to the proceedings. The nucleus is subsequently rotated and all the 4 grooves are deepened progressively. My goal is to reach at least 90% depth so that the posterior plate can be broken with greater ease. In such denser cataracts, you require a little bit of patience. And that's all is required, and most often than not, if you have understood the principles right and follow them appropriately, you can get fairly predictable outcomes with clear corneas on day 1. And at this point, I feel that the grooves are of sufficient depth, and now I can go and attempt the lateral separation maneuver. My right hand has the phaco tip itself, the left hand has the chopper, and the instruments are placed as deep as possible in the groove. This is the most critical step, that is placing both instruments as deep as possible. Then a gentle lateral separation maneuvers on both instruments ensures that the posterior plate is cracked and we have the 2 fragments separated. The nucleus is rotated and the same maneuver of lateral separation is being progressively done. So now we have the 4 quadrants separated from each other and time to emulsify them one by one. It's important to note that the emulsification process has to be done at the appropriate plane. The most important reason for post-op corneal edema on day 1 is the anterior plane of emulsification. If you're able to control and perform the emulsification at the right plane without much turbulence and lens chatter, you'll be surprised that in spite of using significant amount of ultrasound energy, you'll have clearer corneas on day 1. Of course, frequent replenishing of OVDs does play an important role in protecting the endothelium. Now this is the last piece of the fragment, and it's emulsified easily. There is very little cortex left to be aspirated, and it is done with great ease. As discussed previously, in this situation where we have some degree of zonal weakness, my preferred choice is to use the IOL trap technique, wherein we place the haptics of a multi-piece hydrophobic lens in the sulcus and the optic is pushed behind the rhexis and the optic is captured. Space is created above the capsular rhexis and under the iris, and the haptic is gently introduced above the rhexis margin. The trailing haptic is then dialed in. Now we have both the haptics in the sulcus. OVD both in front and behind the lens is irrigated out. With the left hand having the irrigation on, the optic of the lens is now then pushed back using a Sinskey hook, and ovalization of the rhexis does indicate that the optic has gone behind the rhexis margin. I'm using a Kuglen hook to retract the pupil and demonstrate the ovalization of the rhexis at the optic and haptic junction. So it is confirmed at both the ends. And time to close. With the irrigation still in place, I'm going to hydrate the side port and the main port incisions. Sometimes when the rhexis is not very small, the optic capture can get released and the optic can bump out. So that's the reason why I don't want to shallow the antechamber while before coming out with the irrigation. So now all the wounds are hydrated. That's it, the case is done. So in eyes with these progressive zonal weakness, such as in pseudoexfoliation, IOL trap technique is the preferred choice for me, wherein I place the haptic in the sulcus and the optic behind the rhexis margin. And this has helped me to provide a better long-term stability to such eyes. So initially when we used to place both the CTR and the lens in the bag, after maybe a few years or a decade, usually we would see the entire bag lens complex dislocated posteriorly. Well, that incidence is significantly lesser by using this technique in my hands, and that's the reason for my preference for this technique. So that was it. Thank you for watching, and I hope you found this helpful.